Meeting those of you in the audience yesterday, I realized I don't think there might have been someone who calls himself a hand surgeon in the audience yesterday. So I changed my talk last night, sort of on the same theme, but something that's going to be a bit more applicable to most of you in the audience. So this is my preoperative x-ray, a 65-year-old male, still working. Profession, what does he do? He a metal worker, so a pretty heavy laborer. The lateral x-ray, you see the standard dorsal angulation. You can make the argument with me whether I should have fixed this or not, but of course we did fix it. So these are the post-operative x-rays. I believe it's about probably the second post-operative visit, around 1 month from his initial surgery. Obviously, the topic's carpal instability. Anyone see anything going on with this x-ray? Go ahead and yell it out. What? Oh, okay. So a little bit of a gap between the scaphoid and lunate, or scapholunate gap. If you look at the lateral view, maybe a bit increased scapholunate angle. You know, this is the way we measure it. Normal is 30 to 60. There's sort of a wide range of normal. So, yeah, did I miss something in the operating room? Did I miss a scapholunate ligament injury? You would think this hand surgeon has been doing this 21 years, wouldn't miss something like that. But like I said yesterday, there's not a procedure designed in orthopedics that I haven't screwed up once. So it was an interesting, over the last couple decades actually, particularly with the wrist arthroscopy becoming so much more prevalent, people are describing incidents of these, what I call occult intercarpal ligament injuries. What's always been shocking to me is how could I be missing something when the injury rate by these very well-trained and accomplished surgeons is 54% for these intercarpal ligament injuries. Have I been missing something for the last 50 years? And it gets even worse. Even radiologists say they can pick up these sort of scapholunate ligament injuries just by looking at radiographs. I felt better once this report came out that sort of said, look, the way we've been approaching distal raised fractures since the advent of locking plates is a bit different than what we did before. With locking plates, many people are saying, we fix it, it's rigid fixation, we can get you moving right away. Whereas before 2005 or so, different sort of plate constructs or X-fix and pins, which by the way still work very, very well, we slow these patients down. We immobilize them for a month or so. So we think that for these occult injuries, the mobilization we did before allowed them to heal, and clinically it wasn't an injury, a significant issue. So the take-home point I have is if the x-rays look good when you're seeing the patient post-operatively, they have a lot of pain in that acute phase, slow down the rehab a bit, just immobilize them. There's nothing wrong with immobilizing for 4 weeks or so. The final outcome at 12 weeks or 16 weeks is the same as if you start aggressive motion straight away. Now, another point to keep in mind, just like everything that happens to us when we approach 50, 60 years of age, and now I'm over 50, so I hate to say that I'm in this group now, but we know that the incidence of scapholunate ligament, I'll just say abnormalities, I'm not going to say injuries, increases with age. Cadaveric studies show that so close to 30% prevalence of degenerative scapholunate tears. Sort of similar theme. MRI of your low back, once you're over 45, don't worry what it says. MRI of a shoulder, once you're over 65, don't worry so much what it says. Sort of the same with scapholunate injuries, sort of scapholunate abnormalities. So what do you do in the operating room? I actually have been doing this since 1996 when I finished my residency. I just say, get a traction view. We get traction views for ankle fractures for a lot of body parts, right? Now there's a formal name applied to it, the modified carpal stretch test. Essentially, you're just pulling on the wrist either before or after fixation of the wrist for your distal radius. And what we're sort of relying on are these are the galula arcs, right? The smooth arcs of the carpal bones. They should be congruent in all views. When you apply this distraction, you will get a bit of separation between the proximal and distal carpal rows, but notice that it's symmetric. You have these smooth lines that will follow through there. Where a ligament's disrupted, they are no longer congruent. You can't draw a smooth line. It's either a curved, sharp apex, or it doesn't meet at all. So this is a sign of a scapholunate ligament injury. This is the kind of view I get with every distal radius fracture that I do in the operating room. I don't differentiate between the fracture type. I just do it routinely in sort of ways. There's an algorithm, just like we do a pre-flight check with an airplane, sort of do the same thing in the operating room with distal radius fractures. Certain fracture types, like the isolated large radial styloid fragment, does have a much higher incidence of scapholunate ligament injuries. And if you see a scapholunate ligament injury intraoperatively, how do you treat it? The old-fashioned way on the lower right is the Telesnik repair, where you're essentially placing drill holes and passing sutures through the body of the scaphoid. Nowadays, we use MyTech suture. We use mini or micro suture anchors to accomplish the same. You can tell by the plate that I use on this X-ray that it was done quite a while ago. For some reason, I couldn't find X-rays of my more recent scapholunate repairs. The goal is fix the fracture first, and then K-wire stabilization to reduce the carpus, and then your suture anchor repair. And the results were quite good. I will make a note if it is perfectly fine on these acute injuries, if you can easily reduce the scaphoid lunate, I'm fine with doing percutaneous pinning, 3 pins across the scapholunate axis and probably an additional one into the midcarpal row as well. What's fortunate is outcomes after a locked volar plate fixation without a SL injury and volar plate fixation with primary repair of SL ligament injury are equivalent. So there's something different when you have a scapholunate ligament problem associated with a distal radius fracture. The outcomes are quite good. Completely different when you have an isolated scapholunate ligament injury with no associated fracture. Thank you.